right, welcome everyone to the latest edition of Multi-Modality Imaging Conference. I'm Maan Malahfji. I'm one of the new cardiologists here at the Methodist Hospital, and I'm going to discuss the echocardiographic diagnosis and evaluation of pericardial disease. Now, we're not going by seniority level, it's just because I'm doing the echo portion. Dr. Nabi will be discussing CT and CMR, and as you can tell, he's the more established and senior person and the much better dressed. So let's begin. So pericardial disease is very intriguing and very interesting. It's a lot more common than thought, and that is potentially because it's underdiagnosed. Some of the pericardial conditions are very common and some are less common, but the most important portion of this is a very careful history and evaluation, and then on the echocardiographer standpoint, a very careful exam in terms of performance, and then a very careful interpretation. So let's review the anatomy a little bit. The pericardium can be tricky to understand. The way I like to remember it is if you take a balloon and you sort of try to punch a hole into the balloon, you create this double layer that has a virtual space, and the double layer, if you look at the outer one, creates the parietal pericardium. There's two layers to the parietal pericardium. One is the fibrous one, and then the other one is a epithelial layer. And then on the surface of the heart, the epicardial surface, you have the visceral pericardium, which is essentially one layer of cells. Now, under the visceral pericardium, you could have epicardial fat, like you see here, or it can be in direct communication with myocardial cells. And very often, this is the more likely case anteriorly by the RV, whereas posteriorly, this is more likely to be the scenario you'll encounter. So if you look at pathologic specimens here from the ASE guidelines from 2013, you see anteriorly, or at least in this segment here, you see the epicardial fat, pericardium, and then this is fat outside of the heart, which we can see very well on MRI. You can call it either mediastinal fat, or it's also called epipericardial fat. The pericardium exerts a pressure on the heart. If you ever see any cardiac operation, you'll see as soon as the pericardium is cut, it retracts, and that indicates that it's exerting some amount of pressure on the heart to try to keep it from dilating, if you will. And the pericardial pressure usually is very well correlated with right atrial pressure. So let's begin with the relatively simpler cases. So this is a person who's having chest pain and has SE elevations throughout their EKG. And looking at this, you evaluate the patient, you've already diagnosed pericarditis. What is the role of echo in this kind of scenario? If you'll see here, there's this layer that surrounds the heart, and excuse the not so excellent quality images. The layer that travels around the heart here becomes really circumferential, and you see it's not a simple fluid. Now, this isn't diagnostic for pericarditis in of itself, but you could also argue that if this was just pericardial fat, it's unlikely to be extending all the way down. And you see here the IVC is collapsible. That's an important feature to find. So this patient did have pericarditis. It was confirmed on MRI. Dr. Nabi is going to go into this in a lot more detail. And the message that I have for you guys from the echo standpoint is that the echo is often normal, but you have to look for pericardial effusions. You have to describe the size and the location, try to comment on whether it looks like a pure simple effusion or whether it's potentially exudative, where you see fibrous content within the effusion. Look for wall motion changes or changes on strain that can signify any myocardial involvement. And potentially you could comment on pericardial brightness and thickening on the echo. However, this is quite limited, particularly on surface echo, because of changes with brightness being also potentially related to settings on the echo machine. You could theoretically measure pericardial thickness on TEE And this is a study from 1997 that showed fairly good correlation between TE measurements of pericardial thickness and electron beam CT. How do we define sizes of pericardial effusions? This is relatively arbitrary. If you see the effusion only during systole, we tend to call that trivial. If it's less than 10 millimeters or 1 centimeter in diameter, you have to measure it perpendicular to the myocardial segment. That's considered to be small. 10 to 20 millimeters is moderate, and greater than 2 centimeters is large. And like the previous case, try to look for areas of fibrous content, stranding, and adhesions that may help you identify how complex this effusion is. One thing that's pretty important to remember for large effusions, and as we get into the pericardial tamponade, is that the pericardium can be a dynamic structure. So if you create a pericardial effusion in an acute manner, for example, a chest wound, an EP procedure with a limited perforation of a cardiac structure, after heart surgery, you can accumulate a relatively small amount of fluid very rapidly, and that can lead to tamponade, versus the usual potential cancer patients who had quite a good amount of time to develop a pericardial effusion and collect over time. The pericardium will remodel, and they may have a pretty sizable amount of pericardial fluid without reaching tamponade. This is manifested with this compliance curve as we compare the volume of the pericardial fluid to the pressure of the pericardial fluid. As you shift this curve to the right, relatively significant changes in pericardial volume won't exert as much of a change in pericardial pressure. So here's a case of tamponade. What we look for here is the effusion. You see that it's large, it's circumferential. You see how it essentially indents the right ventricle free wall, and you see how here the right atrium is also being indented and compressed during systole. And you notice how the duration of this indentation or compression is pretty significant. You know, this has been looked into, and a right atrial systolic compression of greater than 30% of the cardiac cycle is actually even more sensitive and specific than right ventricular collapse to indicate an echo type of diagnosis for pericardial tamponade. The most critical is looking at M mode. As you know, with M mode, there's excellent temporal resolution. So instead of having to slow down and look at each of these frame by frame, use the M mode pictures to try to look at what's happening to the RV free wall. So here is systole, here's this diastole, and you see the RV is being compressed here. And really, some cases are a lot more straightforward than others. You see the variation in with respiration in the mitral inflow, and then you see the same here in pulmonary veins, and you see the IVC plethora as well. And we'll talk a lot more about respiration changes. Let's begin here. So what is it with the respiratory variation in mitral and tricuspid inflow? To review normal physiology, as the person breathes, as they inspire, the pleural pressure will decrease, and usually it decreases by somewhere between 5 to 10. It becomes negative to let the air in. That change is transmitted to the pericardium and transmitted to the heart, which are all lying within the same structure. So as the pressure decreases on inspiration, the change in the pericardial pressure as well as the transmural pressure on the LV and the LA also change concordantly, and as a result there isn't a significant gradient that occurs between the pulmonary veins or the pulmonary capillaries as you have presumably a PA catheter here. Those don't change, and as a result, a normal person should really have much in the way of a variation in mitral inflow. They will have a little bit of variation on the tricuspid side because as you inspire, you augment filling to the right ventricle. And that's why when you examine pulsus paradoxus on a normal person, you may see 2 or 3 millimeters of mercury of a change, but it won't be beyond that. When you have a pericardial constraint syndrome, such as pericardial tamponade or constrictive pericarditis, the pulmonary veins are not encased within the pericardium, whereas everything else is constrained by the pericardium. So the flow to the pulmonary veins will change in concordance to the pleural pressure, meaning that the pressure in the pulmonary veins will decrease as your pleural pressure decreases as you inspire. But the left atrium and the left ventricle won't get this transmission of pressure change, and the gradient between the pulmonary veins will decrease on inspiration, and as a result the flow will decrease during inspiration. And we'll discuss this a little bit more. Let's get into a little bit more of an interesting case compared to a traditional tamponade. This is a patient with liver failure. He's in the ICU, became hypotensive. He gets this echo done. Notice we have a large fluid here, a large pocket of fluid. It's anterior, and as you get apical views, you see that it surrounds the heart, but notice critically it doesn't surround the atria, and there's a small amount of fluid here, but try to find the descending aorta, and the question here is this truly pericardial fluid or is it something else? And is there tamponade or is there not? If you look at the M mode, you have the mitral valve opening, so this is diastole, and you see the compression of the RV free wall, and you have respiratory variation. So this is a patient that's in quite big trouble, but we don't have a good plan of what to do next. He has a large fluid collection that we get the sense is responsible for what's going on. So if you look at his imaging, he had an X-ray a few days earlier, and now his X-ray shows full whiteout of the left lung. And the cardiologist that's taking care of him is very good. They decided to do a chest tube instead of rushing to do a pericardiocentesis, and notice that there wasn't any pericardial effusion. So going back to the previous echo, you have to pay attention to where the fluid tracks, and this is an extreme case where the large left pleural effusion tracked all the way anteriorly, and this is a good lesson to know that large left pleural effusions can cause hemodynamic features of tamponade, and this was described as early as the 90s. Here's another important caveat to know. Patients with pulmonary arterial hypertension. This is a patient also an extreme case. You see the right ventricle is severely enlarged, severely depressed. Right atrium is severely enlarged as well. The right atrial pressure here, let's say for the sake of the argument, is 25. The patient has a pericardial effusion. It's circumferential. It's not very large, but as you know, it's a sign of impending doom in many PAH patients. You also notice that the left ventricle is almost like a slit, and it actually gets compressed during diastole as well, as you can see from the M mode here, and there is significant variation in the mitral inflow in this patient. So that's another lesson to remember. Patients with very high right atrial pressure, even if the pericardial pressure here is 15 or so, it may never overcome the RV diastolic pressure and the right atrial pressure, and the LV is the one who suffers. Now, do you always have to drain these cases? Not necessarily. This patient was managed conservatively and did okay. Here's another case to remember. Patients after cardiac surgery or thoracic surgery, you may have localized fluid collections, particularly here the concern is hematomas. And look at this patient. You have to know the clinical history, and the sonographer has to be aware of these particular complications where you see this fluid collection here that doesn't really look like pericardial fat, and you see how the motion of the RV here is limited. It's essentially stuck to this segment. You see another pocket of effusion here, and you see all of this collection here. You can have localized effusions that potentially could compress just the RA or the LA. You have to be very vigilant and look for other clues of increased intrapericardial pressure that could explain these scenarios. And that patient had his chest reopened and treated. This is another extreme patient with an LVAD who had severe RV failure right after implantation, needed an RVAD as well. Notice this collection here. Notice how it's complex. It's not pericardial fat for sure. There's another fluid collection here, and notice the organized, if you will, nature of it. And notice how the LV is the one who's being compressed at this point. So he has the problem with RV failure, the problem with the pericardial hematoma, and severe underfilling of the LV that is exacerbated by the LVAD, obviously. But the treatment here, you can temporize them by reducing the LVAD speed and doing other maneuvers, but the patient obviously had to go back to the OR. Remember normal structures that surround the pericardium. You see these often particularly on TE. As you remember, when you create the pericardium from that balloon, at the end of the balloon, usually you'll have what we call recesses and sinuses. You can have the transverse sinus, which is this area here. We remove the heart, and this is the pericardium. The transverse sinus sort of tracks in between the aorta and the left atria, and this can sometimes create confusion as to whether there's a dissection here or not. And then also pay attention to the oblique sinus, where you can have this fluid collection behind the left atria. So remember, for pulsus paradoxus and echocardiographic assessment, if the patient has severe dyspnea or severe COPD with wide variations and swings in the pleural pressure, that can create a pulsus paradoxus type phenomenon. Look for left pleural effusions, very large ones, pulmonary embolisms. This is the classic description of pulsus paradoxus. Notice how, because of the low left ventricular pressure, the aortic valve doesn't open here on inspiration, and this is the paradox where you can hear the heartbeat but you can't feel the pulse. The confounders in pulsus paradoxus, if you have anything that can cause elevation of LV filling pressure, let's say the patient has underlying LV diastolic dysfunction, significant AR, that may attenuate your assessment of pulsus paradoxus. But the critical thing to remember is that this is all the continuum. Now let's talk about this patient. This is an 80-year-old man, came in with heart failure symptoms, leg swelling, early satiety, abdominal swelling, and I think you all know where I'm going with this. He had previous surgery and chemotherapy for his cancer, but no prior history of radiation. No pericardial effusion, but notice how there's no sliding motion of the heart here at all. Notice that this septal motion here is quite peculiar, if you will. This isn't happening every heartbeat, it's happening with respiration. And notice how the LV and the RV are competing for space, essentially. You can visualize these motions much better on M mode as well. You see how, as the patient inspires, the interventricular septum dives down into the LV, and notice that this little sort of movement back and forth, what we call the shudder, is also one thing to pay attention to. Notice that there's already variation in LV flow, and this isn't very clear, but it could be that this beat didn't really result in any meaningful ejection. The patient has low cardiac output. Notice the variation. You have an E to A ratio greater than 0.8. Notice that the lateral E prime is low versus the medial E prime is high, greater than 10. And this is an 80-year-old. A medial E prime, for normal 80-year-olds should be even less than that. And then notice as we look at the hepatic veins, and I didn't show you this, but there's already IVC plethora. Notice these reversals in flow of the hepatic vein upon expiration, and notice how they decrease with inspiration. So this is constrictive pericarditis. The phenomena that occurs with the dissociation of intrathoracic and intracardiac pressure is not very different in some aspects from pericardial tamponade. Here you see how on inspiration there's no residual gradient between the LV, LA, and the pulmonary veins, versus on expiration you see how you have more filling of the LV and the gradient comes back. And these are the changes you're expected to find as you inspire. Flow into the LA from the pulmonary vein decreases, the septum is shifted to the left, and the RV receives more flow at the expense of the LV. As the patient expires, flow improves back into the left ventricle. The mitral inflow increases in velocity, and the pattern changes, as you can see. And you see how the pulmonary vein changes are discordant to that. The septum moves back, and the hepatic veins show you this reversal, because now it's the RV that's struggling to receive more blood. Now, here's another case. For this one, the patient is in AFib. What can we do? There's already variation in mitral inflow here, but one could argue that this is all just AFib. Notice how the heart looks. Notice how it's sort of elongated and tubular. Look at this chunk here that really is unexplained. Notice the paradoxical septal motion and the IVC plethora. So this is constriction with AFib. In patients, which many of these patients will have AFib, the findings of tissue Doppler will still apply, and the findings for hepatic vein Doppler will still apply. So notice how the medial side is very impressive, versus the lateral side is limited. So the Mayo Clinic criteria and the series they have of surgically treated constriction and a comprehensive echocardiographic assessment shows you that if you look for the ventricular septal shift, that's a very sensitive marker. The changes in the mitral E velocity is also pretty good. You don't have to have it. Remember, if the patient has an elevated LV filling pressure, you may not have this much of a change. Theoretically, you could also try to have the patient sit up or carefully diurese him if you want to make that apparent in terms of the change in E velocity. But you have to look for E prime velocity on the medial side being normal or supranormal, and the change in the ratio. And if you combine those first three, the septal shift, medial E prime being supranormal, and the hepatic vein flow reversals on diastole, you can achieve very good accuracy, and positive predictive values are here. You can't really miss it, essentially. So the differentiation between constriction and restriction can come up. This was first described all the way back in '89 from Dr. Hatley, and at the time that was the first description of these changes in mitral inflow with constriction that you do not see with restriction. Since then, this has been a little bit more refined, and this is the algorithm that's really recommended now. You start by establishing that there's a high E to A ratio. The patient has heart failure symptoms, maybe not, because you can have features of constriction, but the patient clinically wouldn't be in constriction, and that could be early features of it, or early features of it. So look for dilated IVC, and then look for the septal motion abnormality, particularly the one that occurs with respiration rather than with every heartbeat. And after that, examine the medial E prime. If you have a supranormal medial E prime or a normal one with these features, you've gotten pretty good accuracy and confidence in making the diagnosis, versus if it's reduced, you have to look into restriction, and then you can always have cases with a mixed type of scenario. Now, you could theoretically have those two scenarios occur in patients without constriction, particularly patients with COPD or the young patient with asthma that's coming in with an exacerbation. They'll also have wide swings in their pleural pressures and a change in their E prime, in their E waves, as they're breathing in and out very rapidly. So a significant respiratory effort can create these kinds of changes. However, what we look for in this kind of scenario is examining SVC flow. And I won't delve too much into it in the interest of time, but SVC flow should change in these kinds of patients, whereas in constriction it remains unchanged with respiration. So here's a comparison between restriction and constriction. As you see here, you have a severely dilated by right atria and left atrium. The E prime on the lateral side is reduced. You have this restrictive filling, which you see the deceleration time here is very short, and you have respiratory mediated flow reversals in the hepatic veins, but they occur on inspiration. So this is restriction, versus here, where you have them on expiration, and this is constriction here. Okay, let's discuss this case. So there's a person with end-stage renal disease, prior kidney transplant, now has advanced chronic kidney disease also, and he has this large effusion. The patient underwent a pericardiocentesis. The effusion resolves initially, and notice what's going on with the IVC here. This is sort of a magnified view of it. You see you have normal type of hepatic vein flow, but notice these changes here. Notice that you have these diastolic flow reversals that occur, and the sonographer here put on the respirometer and notice how you have these changes. The patient was readmitted a month later, recurrent pericardial effusion. Notice that the effusion now is different than before. It was purely simple previously, whereas now you have this complex nature of it and this fibrotic material. So this time he had a pericardial window. The biopsy commented on inflammation. The surgeon said that the surface of the heart appeared inflamed. And a month later, he came back with another hospitalization for heart failure. He had large bilateral poor effusion, no pericardial effusion on the echo, but look at the Doppler and notice that lateral E prime reduced, medial E prime reduced, but significantly better than this. And notice how it actually even changes with respiration, but here it's almost hitting 10. And notice the variation in the mitral inflow, as well as the diastolic flow reversals on the hepatic veins. So this is effusive constrictive pericarditis. It's uncommon. It has features of an effusion, but with a visceral constriction. And the classic definition of it is that a person would come in with pericardial tamponade. You would drain the effusion, but they still have elevation of intracardiac pressures. So in contrast to constriction, the run-of-the-mill constriction, you wouldn't necessarily see pericardial calcifications, which are already not necessarily a definitive requirement for constriction. Remember, effusive constrictive pericarditis in three main scenarios, but really it's the first one that you always have to think of. Patient presenting with tamponade, you train the effusion, elevated filling pressures, he comes back later with heart failure. Or someone who has a chronic or subacute sort of constriction type scenario, but still has a pericardial effusion. Or someone who's had a pericardial effusion for a long time and still has, or comes in with heart failure symptoms. Think of all of the end-stage renal disease patients, the breast cancer patients that have these effusions for the long run, and eventually come in with heart failure. So effusive constrictive pericarditis is, I would argue, quite underdiagnosed. The patient that I showed you was treated with steroids and he improved. The most recent series from Mayo also had 205 patients. These were patients who underwent pericardiocentesis, so this is the selection criteria for this study. There were features of constriction in about 16% of those. The pericardial fluid had parameters that you'd expect, where it was more likely to be exudative, high percentage of neutrophils, fibrinous effusions were more common. And on follow-up, which extended to 3.8 years, only 2 of those needed surgery. So identification is critical because, especially now with newer drug therapies for pericardial disease are coming up, the potential of saving these patients from having to have surgery or treating them rather than allowing them or blaming the heart failure admissions on something else can be critical. Now, can you have constriction with a normal pericardial thickness? And the answer is yes. The recent study, well, it's not recent, from 2003, another series from Mayo showed that about 18% of patients with features of a constriction on hemodynamics and echo had normal pericardial thickness on CT or on a surgery. So don't exclude it based on CT findings, for example, and echo has to come first in evaluating these patients. And critically, treating them surgically with pericardiectomy was equally effective, whether they had an increased thickness or not. So my message regarding CT and MRI is, remember that echo will be the first modality in assessing these patients and potentially guiding their treatment. You could make the diagnosis with echo, you could decide on treatment strategies potentially with echo, but remember that MRI and CT can help you guide your plans for surgery if it's planned, or for some people, particularly think of those with effusive constrictive, if you have persistent changes that could on MRI, CT, that can help you decide on plans for treatment. So I'll go through these real quickly. Pericardial cysts, Dr. Nabi will go through. We find them incidentally. I haven't seen anyone have complications from a pericardial cyst, but you could theoretically have infection, hemorrhage, and rupture. Pericardial tumors would probably be one of the rarest findings you can find on echo, but think of pericardial mesotheliomas. And remember that cytology after you drain a pericardial fluid is very often of limited value. And I'll leave you with this last case. So this is a young person, comes in usually with atypical symptoms. Notice how difficult the echo is, and notice how the right ventricle, right atria appear quite large. Notice how there's an abnormal and quite strange motion to the heart. And once you see these kind of scenarios, this was described previously as sort of a teardrop shape. Think of congenital absence of the pericardium, and that was what's proven on this person's CT. You see there's a hint of small amount of pericardium here. You can have complete absence or partial absence, and usually it's more likely to be men. Abscess on the left side is more common. You could have coexisting anomalies, and theoretically you could also have a partial absence and potential entrapment. There's been descriptions of the left atrial appendage being entrapped. But usually it's a quite benign condition. So with that, I'll stop here, and Dr. Nabi will take it from here.
Thank you very much, Maan. Thank you very much, Maan. I really appreciate it. Great job. Before I get going on my talk, I just want to remind the audience, please join us for a conversation afterwards. You can join on the web. Go to polev.com and just enter in DeBakey, and you're able to ask your questions that way. Or you can even join us by text and simply just text DeBakey to 37607, and if you'll ask your questions that way, Maan and I will do our best to answer them. So I was charged with speaking on CT and CMR for pericardial diseases, and I completely agree with Dr. Malahfji that echo definitely, because of the hemodynamic information you get, that really is the first line test in the diagnosis and management of these patients. However, as you know, with echocardiography, there are some times where you can run into difficult image quality. Patients may have limited windows, being in a post-operative state. They may have some technical difficulties in patients who have obesity or COPD. We know the pericardium can be very difficult to see because of the poor signal-to-noise ratio. And definitely when it comes to tissue characterization, we have some limitations with echocardiography. So for all of those reasons, there is a cardiac MRI and CT to the rescue, which can definitely complement echo. And we know these techniques have a lot of advantages when it comes to imaging, specifically their spatial resolutions and their ability to image the entire chest. But these are techniques where, since we are talking about pericardial disease, that these are techniques that can actually see the pericardium and really investigate its nature. So, you know, when it comes down to choosing between CT and CMR, there are recommendations of which test to choose, but I try to make it a little simple on the screen there for you. when you have a patient and you really need to know anatomy, CT is the way to go. It has the highest spatial resolution. We definitely think it's great, for evaluating extracardiac disease, for preoperative planning, and for evaluating calcium. Remember, CT sees calcium very, very well. Cardiac MRI also sees anatomy very good, but its real strengths are also being able to image physiology. So you can actually see hemodynamic changes, and of course its most unique strength that it has is the ability for tissue characterization. So anytime you need tissue characterization that includes the ability to see inflammation, CMR would be a very good choice. We've discussed with Echo some of the spectrum of disorders that you can see. I also will be discussing these, the types of disorders that can be seen, and I've chosen just a few for the sake of time. But before I can get into these diseases, I think it's important for me to show you what a normal pericardium looks like with these different imaging techniques. So here we are with a cardiac MRI, and to image the pericardium we use a sequence called a T1 spin echo. And the pericardium is shown there by the arrows, and it's this really thin curvilinear structure that circumambulates the heart. And in general, the pericardium is very thin. It's less than 2 millimeters, and anything more than 4 millimeters is pathognomonic for pericardial thickness. Other things to keep a note here is the pericardium generally is very well seen anteriorly over the anterior portion of the heart, because that tends to be where all the fat is, as we saw in some of those pathological images by Dr. Malahfji. Whereas on the posterior lateral portion of the heart, there's less fat there, so you tend to see it, it's less evident there because you don't have the surrounding fat to bring it into the picture. The other thing that's important with cardiac MRI is to know a little bit about the sequences that we use. Our first sequence that we use is what we call our SSFP sequences. These are basically showing us the heart in cine motion. We then have a sequence called the T1. If you'll remember, T1 shows us the pericardial thickness. It can show us effusions, as we discussed in the last slide. We then have sequences that we call T2 sequences, which are really our water imaging sequences, or in this particular case, edema sequences. And then finally, we have sequences which show us late gadolinium enhancement. And here specifically, whenever the pericardium takes up LGE, it's important to realize that this is an inflammation, and we're going to talk about this more in the upcoming slides. But in this images I've shown here, the fact that you do not see any brightness on the T2 or LGE sequences shows that there's no edema or inflammation in this particular patient's images. Just remember this, that this is what normal looks like. Similarly, when it comes to cardiac CT, we can also, of course, very nicely, because it's great at seeing anatomy, we can definitely see the pericardium very well. Now, with CT, you do not necessarily need contrast. You can image the pericardium simply with a non-contrast CT through the chest. So I've shown you both images, what it would look like, the pericardium, both without contrast or if you were to administer contrast. In both, you can see the pericardium looks exactly the same. So let's talk about some of these different disease processes and how we can image them with these advanced imaging techniques. So this was a 48-year-old male. He had positional chest pain of recent onset. His physical exam really was normal. There was no rub evident. EKG just showed some early repolarization. His troponins were normal. He actually went an ischemic workup, which was normal. And here are his ultrasound images of his heart. And I think y'all would agree with me, at least LV size and function look normal. And we see some a dark layer just posterior to the LV and posterior and posterolaterally. This patient went on to have a CMR, and we'll discuss why, but just is also to show you what our capabilities are with this technique. So this is that exact same patient's CMR, and what you'll notice is very similar findings to what we had seen with our transthoracic echocardiogram. You see definitely a layer of tissue here posteriorly, very nicely in these short axis chamber of the heart, and you can actually, because we can see the right ventricle and anteriorly very well, you can also see that the same process is occurring anterior to the RV. When we start applying some of our different sequences, you can see on T1, where we look for thickness, you can see that the pericardium is markedly thickened. If you remember when I had showed you last time, this is normally less than 2 millimeters. This is on the range of 4 to 5 millimeters here. So the pericardium is markedly thickened. Similarly, if you look at our T2 sequences, if you'll remember, that is our edema imaging, that same dark thickened area on the T1 images appears very bright this time on the T2 images. This indicates edema. So this pericardium is not only thickened, but it is edematous. Finally, the last sequence that we use with CMR is LGE, and what I'm trying to point out in these two different ways that we can image the heart, you can see diffuse hyperenhancement circumambulating all around the heart. This is the pericardium taking up gadolinium contrast pretty intensely, and you can really appreciate these on this 3D cine acquisition. So really the end consequence here, diagnosis for this patient that you can confidently say is that this patient has acute pericarditis. Now, if you look at the ESC criteria for making the diagnosis of acute pericarditis, you need 2 of 4 criteria. You need chest pain. Now, vast majority of patients will have that. You need either pericardial rubs. The problem is, you'll notice only 33% of patients present with rubs, so this is not a common finding whatsoever. You can have another feature that you look for is diffuse ST elevations on your EKG. Notice 60% of patients will not have this finding. So again, not common finding to see in acute pericarditis. And then finally, pericardial effusions. So you need at least 2 out of 4 of these to make the diagnosis of acute pericarditis. And notice pericardial effusions can not occur in almost a third of patients. So we really, sometimes, we have clinical uncertainty when we are taking care of patients, and we would love a technique that can help increase our specificity. And that's where really CMR can come in. It can help us readily identify pericardial effusions, especially those are loculated that you may not be able to see. And then also the ability to be able to see pericardial inflammation, which again increases your specificity that you are dealing with a pericardial process rather than chest pain due to some other cause. And this was just a study in 120 patients who had idiopathic recurrent pericarditis, and really just showing us that if you combine features of pericardial inflammation with LGE, you really increase sensitivity and markedly increase your specificity in making the diagnosis of pericarditis. Now, this patient, the same patient I showed you went on, was treated with anti-inflammatories, and I hope you'll appreciate that diffuse hyperenhancement that I had shown you around the heart has completely resolved. You can see the same phenomenon here in this patient who pre-procedure had before pulmonary vein isolation, had an MRI. Post-procedure complained of chest pain. There was diffuse hyperenhancement both on T2 indicating edema and LGE indicating inflammation. This patient was treated with anti-inflammatories, brought back to the lab with resolution of their symptoms and resolution of the edema and LGE, showing you that CMR can be used as a guide to following patients serially in order to assess the state of their inflammation. Let me show you another case. 34-year-old male, history of ASD closure remotely, presents with acute chest pain after a viral prodrome. This time his troponin is positive, has a CTA that was completely normal. Here are his here's SSFP images, Arsini images. You can see here the patient has a pericardial effusion, small to moderate, generally a lot of it laterally. You can see that the fluid looks very turbulent inside. It doesn't have a very bright signal on the SSFP images. But when you turn on the tissue characteristics with LGE, you will see that not only do you have hyperenhancement of the pericardium, here you can see this bright layer here, this is the visceral pericardium, and you can also see this brightness here. This is actually the parietal pericardium that is surrounding this pericardial effusion. So you can actually see hyperenhancement of both layers of the pericardium. But in this particular case, if you closely observe the myocardium, you'll also see patchy hyperenhancement of the anterior wall here on the short axis image, as well as the two-chamber view, showing us that this case was actually a case of myopericarditis. Here was another patient, 51-year-old, had a STEMI week ago, had his LAD fixed, and returns with positional chest pain. You can see a small to moderate circumferential pericardial effusion. You turn on your tissue characteristics. This effusion was new. You turn on your tissue characteristics. Again, you can see hyperenhancement by edema imaging of the visceral and pericardium. But and then when you look at the LGE, you can see evidence of his old infarct. So this is really an example of post-infarct pericarditis. So, not everybody needs CMR, CT imaging when it comes in acute pericarditis. There are tables out there that can help you, but do consider these advanced techniques whenever you have a patient who has a complicated course, recurrent symptoms, suspicion for constrictive features. If the disease is caused by traumatic injury, you really need to be able to see the entire thorax, or if there's any associated diseases such as neoplastic processes, pancreatitis, aortic dissection. And those are situations where advanced imaging would be very helpful. So let's move on to another disease state. This was a 47-year-old who presented to the ED with 7-month history of right heart failure symptoms, progressive dyspnea on exertion, lower extremity edema, fatigue, and right upper quadrant pain. Physical exam showed elevated GVP, which increased further with inspiration. There was no rub. You felt a large liver and the legs were swollen. Labs really were uneventful. And if you look at some of the echo images, these are a lot of the features that Dr. Malahfji mentioned, showed us very nicely in a lot of his images. You see a diastolic septal bounce. You see restrictive filling pattern and respiratory inflow changes across the mitral and tricuspid valves. You see evidence of annulus reversus, where the septal E' is larger than the lateral E', and you see evidence of annulus paradoxus, where the filling pressures is actually related to the inverse of the E to E'. You see obviously plethora. And if you look at the spirometry of the hepatic veins, you see evidence of hepatic vein diastolic flow reversal upon expiration. So this was a slam dunk for you to make the diagnosis of constrictive pericarditis, and which we've heard is really due to a thickened, inelastic, scarred pericardium. And you really need 3 features that are very, very important. You need dissociation of intrathoracic and intracardiac pressures. You need evidence of ventricular interdependence, also known as ventricular coupling, where one ventricle fills at the expense of the other. And you need elevation, equalization of cardiac filling pressures. And these are all just going over some of the features that Maan has already mentioned. But here's my question to you. What would you do with this patient? Are you going to send him and further try to refine the diagnosis by doing an invasive left and right heart cath? Will you send him for stripping? And you know this can be a difficult surgery. Will you just simply start him on anti-inflammatories? Will you give him diuretics for his right heart failure? Or are you going to consider further imaging? Well, this is an imaging talk, so you would be right if you guessed imaging, but my job is to tell you maybe why this was the correct choice. So here are this SSFP images, and right away you can appreciate, although we tend to use the T1 to look at pericardial thickness, compared to the other images I've shown you, you can see this profile that this pericardium is thickened around the heart. If you look a little bit further, you can see, if you look specifically at the septum, at the 3-chamber or 4-chamber views, you will see what they call a septal bounce or a septal shudder, or a very early diastole, you'll see movement towards the LV. Again, usually this is with respiratory changes and not with each cardiac cycle, as was mentioned. So these are features, again, that hemodynamic features, again, of constrictive pericarditis. And this just goes over a little bit of what we heard, you know, in patients who have constrictive pericarditis. You know, you have dissociation of intrathoracic, intracardiac pressures. When the patient inspires, there's a lack of a gradient between the pulmonary vein and the left atrium, which leads to left filling on that side, more filling on the right side, which pushes that ventricle towards the left. And this is, and the way to describe it again is this bounce or this shudder or this S-shaped motion of the septum. This all describing this phenomenon of ventricular coupling. We then can, this can also be seen with what's real-time cine imaging, where we can just image the patient as they free breathe. And what you'll notice is, as the patient inspires, when the abdomen drops, you will see just a very subtle shift of the septum towards the left. Again, this is all just further evidence that the two ventricles are competing with each other, and one is filling at the expense of the other. Again, pathognomonic for some pericardial process. We can, with CMR, use real-time imaging and look at flows across the mitral tricuspid valves, and also see respiratory variation using specific sequences. And we can look for indirect evidence of elevated filling pressures in this heart. Here in this patient, you can see the IVC is plethoric and is not collapsing. You can see evidence of right atrial enlargement, evidence of pleural effusions. Notice we can see the entire thorax. You can see into the abdomen. You can see how big this liver is, and you can see evidence of ascites. So all evidence of elevated systemic venous pressures. But of course, what do you call it? The strength of CMR, again, is in its tissue characterization. This is a technique that can actually look at the pericardium directly, where the disease process starts. And if you look at the pericardium here, you can see it's circumferentially thickened on these T1 spin echo images, here measuring 5 millimeters, which is thick and specific for constrictive physiology. You can also look at the interaction of the pericardium and myocardium using these tagged sequences, and as was mentioned, you basically do not see slippage of these two structures independent of each other. Rather, they seem to be adherent and moving together. Of course, tissue characterization is the strength. So when we look at our T2 imaging, which is our edema imaging, again, that same thickened area that you saw on T1, which is the pericardium, now lights up bright on T2 imaging, indicating it's swollen. And when you administer LGE, there is diffuse hyperenhancement of the pericardium, indicating an active inflammatory process. How do I know this? This was a study in 25 patients with constrictive pericarditis who all underwent pericardiectomy following CMR. And those patients who had pericardial LGE all showed by histology evidence of active inflammatory process, which included significant increase in fibroblasts, chronic inflammation, neovascularization, and granulation tissue on histological specimen. This present patient happened to also get a non-contrast CT, so I bring these images here just to show you what a thickened pericardium would look like and what features you would look for. And you can see this is a markedly thickened pericardium, again circumambulating the heart. Again, a great technique to see the pericardium and a great technique to see calcium, which this patient does not have. Limitation of CT, of course, is you do not derive much direct hemodynamic information. So now that I had asked you that question earlier, do you change your mind? Would you do anything differently with these images that I have shown you? And I think hopefully my point here is that you should consider anti-inflammatory therapies because of the amount of inflammation you are seeing. This is this patient who was treated with triple anti-inflammatories and aspirin, colchicine, and steroids, and you can see complete resolution of the thickness of the pericardium, the edema around the pericardium, and the LGE of the pericardium. And this is just an image of the comparison side by side, pre-therapy and post-therapy. This was a study just showing you that in patients who had reversible constrictive pericarditis, 93% had moderate or severe pericardial LGE. So this can really identify a cohort who have reversible disease. So not all patients need to undergo pericardiectomy. Take a look at this heart. Same case, 80-62, atrial fibrillation this time, right upper quadrant discomfort, lower extremity edema, several years duration. There are a lot of interesting features that you're going to find. You're going to see what was mentioned. You'll see this kind of very thickening here. You can almost see that these ventricles have assumed a tubular shape. You can see this abnormal septal motion. If we look further, with our tissue characterization, you will see on our T1 images marked thickening of the pericardium here anteriorly. But look at the T2 and LGE this time. It's completely dark around the heart. There's no evidence of edema and there's no evidence of LGE. So I would ask you in this case, what would you do? Are you going to do anti-inflammatories in this case? Would you send the patient directly for pericardiectomy? Maybe further non-invasive, invasive imaging, diuretics, for consider further imaging. So this is, you're absolutely right. This is a case where this patient was not having active inflammation. And if you take a look at this patient's CT here, you can see again that thickening that we were seeing on CMR is actually not thickening. Very nicely seen by CT. This was diffuse calcification anteriorly and posteriorly around the heart. This was a non-contrast CT, but just looking closely at the shape of the ventricles, again, you get that feature that these ventricles have been squeezed, their tubular nature, and you can see flattening of the interventricular septum. So a lot of information that can be learned simply by a non-contrast scan. And again, important point here is that pericardial calcification really represents end-stage disease of fibrosis and inflammation. CT has another strength here where it can be very helpful for the surgeon. He can really kind of see the, in a 3D perspective, how the calcium is encasing the heart, where all he may have to chip away at this calcium to, free this heart. So it can be very helpful in planning his surgery. But more importantly, if this patient also had CAD, you can assess the CAD, assess his coronary grafts, and in patients who have a history of known radiation exposure, look for radiation damage to other portions of the lung. Here was another case, non-ischemic cardiomyopathy patient who presented with right heart failure symptoms and was correctly referred to the CMR lab for pericardial evaluation. In this case, if you look at the pericardium, it was thick, but it was about 2 to 3 millimeters, which is about an intermediate thickness. Let's turn on our tissue characteristics. And this time, it's a very different pattern. Instead of seeing LGE uptake in the pericardium, we notice diffuse PACC uptake diffusely in the myocardium. So this was not a disease of the pericardium, rather this was one of those restrictive disease that was mentioned and we have a technique here, CMR, which can actually assess the tissue properties of the myocardium and here accurately diagnose an amyloid pattern. And this is just a slide to help you in when you should consider advanced imaging, and really consider advanced imaging whenever you have uncertain results, or whenever you want to assess for inflammation to look specifically for reversibility or response to therapy. So pericardial masses, for the sake of time, we're running over. I will just say a few brief words. CMR's real strength here is its spatial ability to see anatomy, and then of course tissue characterization, tissue characterization, tissue characterization. Here's a large mass outside of the heart, really not compressing it, just based on how it looks on T1, dark on T1, bright on T2, no contrast uptake. Very simple for us to diagnose as a benign cyst. Similarly, here's another mass, right posterior to the right atrium. This has a different way. It looks bright on T1, dark on T2 with fat saturation. Nothing can do this other than fat. This was a lipoma of the heart. So contrast this to this case. Here was another mass in the infralateral portion of the heart. You can see on T2 it's bright, but this time whenever you administered contrast, both on the first pass perfusion and LGE, you had contrast uptake of the mass. This is a very important point I'd like to take a brief note and pause on, that whenever you have contrast uptake of a mass, this is a tumor, period. I'm not saying this is benign or malignant, that we have some shades of gray on, but however, this is, when you have contrast uptake of a mass, this is a tumor. And this was shown in this study that a tumor, when you're comparing thrombus to tumor, tumors always take up contrast. And this was another example of a case we have published as well, a large mass in the pericardial space that was invading through the heart, and if the tissue characteristics took up contrast, and on histology, when the patient was sampled, you had you diagnosed a cardiac sarcoma. I'm going to skip these two slides and just also show a similar case. Be on the lookout. We do see this. This is very easily diagnosed. Abscences of the pericardium. The way you can quickly make the diagnosis is when the heart is completely shifted over to the left, and when you have a lung tissue in between the aortopulmonary space. So whenever you have this is very pathognomonic of absence of the pericardium. Here's a case where you had partial absence and you actually had herniation of the apex through this partial absence of the pericardium. So please don't forget CMR CT. It is considered appropriate by the appropriate use criteria. I hope I'll summarize it that pericardium can be affected by a variety of systemic and primary diseases. Echo remains the first line test. CT and CMR allow excellent visualization and characterization of pericardial pathology. Consider CT whenever you need to know anatomy. It's fantastic for calcium locating disease, planning, pre-op planning, and coronary evaluation. CMR is great for when it comes to physiology, which includes looking for inflammation, hemodynamics of the heart, and tissue characterization. Well, I will pause there. I hope you enjoyed this lecture on pericardial diseases. And we are very much looking forward to questions and answers.
It looks like we did a good job. I'll take that, because we haven't gotten any questions from Paul EV. Any questions from Zoom, the local group here? All right. Or comments? All right, well, it looks like we're good. So we'll see you guys next week. Thank you all.
Bye-bye.